Hello everyone, welcome back to another episode of Research Works podcast. We're here at EACD Galway Ireland 2026. So, how have you been going with all the episodes? What have you been listening to? What have you been enjoying? I hope there's been something for everyone here. This conference has got so many topics across all of the F words, and it's been really lovely talking to people about areas of interest to them and just some new work that's been happening from around the world as well. So I hope you've been enjoying everything that we've been talking about so far. If you're into anything related to orthopedic surgery, well, I've got one that will be very exciting for you. My guest today is Nancy Lennon. Welcome to the podcast.
Thank you. Great to be here.
Lovely to have you here. Look, I read the title of your presentation and thought I definitely need to speak with you. It's something that really pulls me in, and I'm sure a lot of our listeners would be really interested in this as well. And the title is, Does Multi-Level Surgery Weaken Muscles in Ambulatory Youth with Cerebral Palsy? It's a good question.
Yeah, it's a question I think some physical therapists are already biased towards, thinking that surgery does weaken muscles. And
I know, that's the first thing I thought. I was like, well, of course it does. So why are we studying? It's good.
Right. Yeah. Appropriately cautious with their families. Be careful of surgery.
Yes.
You'll be weaker. And we need to explore that question.
I love that you did, because I think what's been really clear in this conference is sometimes there's a lot of perceptions that have been sort of passed down from generation to generation that we just take as truth, as part of how we practice.
Yeah.
And every now and then you just kind of need to stop and study and look at the actual evidence for it.
Yes, absolutely.
Tell me a bit more about the background here, Nancy. Why, I mean, we kind of covered it there, but why did you really want to look at this?
Well, as you already said, it's a question that I think especially physical therapists, working with children with CP have, and I have the opportunity to answer that question with data from the Gait Analysis Lab.
Great. Okay. So this is from real clinical-based data. It's in terms of like actual practice that's happening right now. It's real life work.
Correct. Yeah. The data is from our clinical database where we test young people with CP.
Right.
The data for this study is from a group who was anticipating surgery. So a pre-surgery, pre-operative gait analysis. So we have data over the past 15 or 20 years that we pulled from to try to answer this question.
Okay, so how many individuals with cerebral palsy were included, and do you remember roughly their ages? You don't have to remember the stats. But roughly.
Yes. No, just gave this presentation yesterday, so pretty fresh.
Oh, good.
There were 245 children with 270 to 270 something gait analyses. So a few kids that came more than once, but so roughly 250.
Wow. And age range for these children and GMSS levels?
6 to 18.
Okay.
Average age 12. It's pretty typical for a surgical cohort.
Yeah,
Plus it's right in the middle of a pediatric age range. 11, 12.
Sure.
And then GMFCS levels 1, 2, and 3. Okay. 56% at GMFCS level 2. Okay. So maybe 15% at level 1 and 35. Is that up to 100? At level 3?
Something like I'm not
but mostly GMFCS 2. Yeah, I didn't.
Interesting. And that even as you talk about that, reflects a lot of clinical practice, isn't it? Where we would know that mostly these will be the groups you'll be seeing these surgeries for.
Yes.
And what kind of surgeries were they actually going in for?
Yeah,
when you say multi-level, because that's,
Right, determined by the gait analysis. So it was clinical cohort. So these children and families came anticipating the likelihood of surgery, but the gait analysis helped define the surgery. Yep. A wide range of surgery, from simple soft tissue procedures, maybe a calf lengthening or hamstring lengthening, all the way through, bilateral femoral osteotomies, tibial osteotomies, foot reconstruction.
Okay.
So our interest was in just kind of throwing everything together into a broad, multi-level surgery, not so specifically at a type of surgery and a single muscle. But, kind of
what does
casting
actually
a
look like
wide
in
net.
clinical practice.
Yes. Again, that's our
Tell me about
motivation.
how you measured muscle strength.
So this is, again, I keep going back to it, hope it doesn't sound like a broken record, a clinical cohort. So we measured it the way that physical therapists measure muscle strength every day in the clinic with a manual muscle test. So because we are in an accredited gait analysis lab, we have to demonstrate that we're reliable in administering manual muscle testing. So there's 5 therapists in our lab. And twice a year, we go through this process of looking at our inter-rater reliability, which is 85%, 85 to 90%. So we spend a lot of time on that. So we felt very comfortable using manual muscle testing data. One of the things we did to help with our clinical interpretation of the analysis was convert the 0 to 5 manual muscle testing scale to a percentage scale.
Oh, tell me about that.
So a 3 is 50%.
Okay.
A 5 is 100%. And then we use plus and minuses with the manual muscle testing scale. So there's a protocol actually described by Florence Kendall way back in 1971 or 1972.
Yes.
Do you have the green book? Yes, everyone recognizes. Yes, the Kendall book. So there's a conversion from 0, which is 0%, to a 1, 2 minus, 2, 2 plus, 3 minus, which converts to percentages.
And why is that advantageous in research? Because obviously clinically you would the 2 minus, the 3 plus, we all know what that feels like. But the percentages are useful mainly for research purpose, for analysis,
I feel like
do you think?
More for clinical interpretation. So, I mean, we, as physical therapists are very familiar with the scale. So if you were to look at the paper and say, the average score was a 3 minus, or 4 minus, maybe a little more intuitive to see 80%. Strength, 60% strength. So for those reasons,
it's a good reminder actually, because clinically, I think I've just used the ratings, the 3 pluses, but also it is. What does a 3 plus mean to a family as well, right? Oh, they're a 3 plus, and they're like, what's the difference between that and a 4 minus? And we can talk about that. So really interesting and a good reminder about that. Okay, so what did you find? What was your big result from this, and did anything surprise you about it, Nancy?
The major, the big picture takeaway was no decline in manual muscle testing scores from pre-surgery to post-surgery.
Wow.
So an average of 15 to 18 months post-op.
Right.
So beyond a year, during the second year that the patients, that the children come back for a post-op gait analysis, do the same manual muscle testing.
Right.
And in our analysis of those 274 visits, very broadly, no change.
Wow.
Like no loss of strength. We did some sub-analyses that showed in what situations things got better and in what situations things got worse.
Tell us about that.
Yeah, so the interesting thing we actually haven't talked about yet, we looked at muscle performance. So in 2 ways. We looked at muscle strength, which we talked about with the manual muscle testing scale. We also looked at power generation.
Oh, of course. Yes. I'm seeing that in the abstract.
Right. So in our setting, in a gait analysis setting, we're able to do that because we have kinetic data from when the children walk across a force plate that generates data on power generation in each body segment. So we looked at the foot and ankle. So we looked at ankle power generation. And we looked at the femur, at the hip segment, hip extensor power generation. So those are the 2 places during typical gait that you get your power to propel yourself forward.
And that's fantastic to look at that, isn't it? Because yes, you've got an assessment of capacity essentially, but you actually want to see what it looks like in real practice.
Right, in real practice, right.
No, when you actually walk.
Performance.
Yeah,
and
that's
gait,
right. Yeah,
so,
wonderful. Yeah.
So, like I said, we did have the opportunity to look at in different situations when things get better and when they might decline. So, and the power data is where that's the most interesting, I think. So one of the things we did was in outcomes going back to function, we defined in this cohort two groups, a group that had what we called a good functional outcome and a group that had a poor functional outcome.
Yeah.
And we called a good functional outcome one in which gait speed was maintained or improved.
Okay.
And we called a poor functional outcome one in which gait speed declined by more than the minimally clinically important difference.
Right.
Which others have defined for youth with CPHE FCS level 1, level 2, level 3. So it's a little different in each group.
Sure.
And we were able to apply those numbers, those minimally clinically important differences at each level.
And is that using like a 10-minute walk to, like, what's the minimum clinically important difference? Is it for like a walk test or?
No, it's just based on gait speed, not using 2-minute, 3-minute, 6-minute walk tests.
Right.
So we just use the gait speed from the temporal spatial data from the gait analysis, right? We have the outcome of speed. So we used that to stratify the group into two, good functional outcome and poor functional outcome.
Right.
So it's about 65% with a good outcome, 35% with, unfortunately, a poor outcome.
Okay.
But having that breakdown, then we were able to look at the strength and the muscle performance, the manual muscle testing scores and the power in both of those groups.
Yes.
In the group with the good functional outcome, we actually saw in the manual muscle testing score some improvement in hip extensor manual muscle testing scores and in ankle dorsiflexion and plantar flexion manual muscle testing scores. And no change in hip extensor power generation and an improvement in ankle power generation.
Right.
Right? Which
that
you
makes
said,
sense.
right?
I like that.
You're walking the same or going a little faster.
That's right.
And then contrast that to the group who was classified as having a poor outcome because they lost walking speed. We saw no change in manual muscle testing in that group, kind of consistent with the broader group. But with the power generation data, we saw a decline in ankle power generation, quite a significant decline in ankle power generation.
Okay.
Which makes sense. So the question then, you might be thinking in your head.
I've got many questions.
Chicken or the egg, right? They're walking slower, so they're generating less power at their ankle. Right, they're walking at a slower speed, but we don't know why they've chosen that speed.
Sure.
So back to the gait analysis. We just have children walk at their self-selected speed.
Sure.
Both for the pre-op and the post-op. So it was the child's self-selected speed, and unfortunately, the post-op gait analysis, they're choosing to walk at a slower speed. So we don't know. Is it because they've lost ankle power, or is it for some other reason?
Of course.
Then we're just recording lesser power.
Yes. There's a lot of interesting factors there, isn't there? I mean, part of me is on the walking speed, I guess if I start there, it's interesting, we do walking speed that's self-selected a lot of the time, but then there are tests where you can go, okay, walk as fast as you can. Because I do have, and it's only come up when some children say to me, well, do you want me to walk fast or am I normal? And some kids just don't know what their normal is. They'll just go, I'm just going to walk. And then it does influence those outcomes. So it's an interesting one. But the other question I had was, often post-operatively, after you have surgery, people have maybe more focused therapy or support afterwards, because this was measured 15 to 18 months post. Do you have any ideas on whether the group that, had a good outcome, was there any relationship to any therapy they had or access? I mean, is that something to explore?
Well, certainly something to explore. We don't have that as part of our data set.
Sure,
We're separately looking at that. And at our center, we follow kids pretty closely. We try to keep a close eye on the therapy that they're getting. But this leads us to
It always does.
more questions, right?
Yeah,
of course.
Yeah, that's right.
That, maybe in that group, or maybe in general, do we need as physical therapists to focus more on power?
Yeah, that's right.
And walking speed and power. And is that what explains the result in the poor outcome group?
And it's good to have, from a research perspective, to have these two different groups to be able to sort of work out from a precision perspective what we need to do. I think about the work of Noelle Moreau and Chrissy Bjornsson. You go, power, we need to be specific, and sometimes we think about strength, but power training is a different thing altogether, isn't it?
It is, yes.
Yeah,
it is.
so it makes you think about putting all those things together.
Yes, yes. And one of the things we didn't do, which has come up, actually I had a great question yesterday about it, was should we be looking in our gait analysis at fast walking speed? You just brought up, some kids would ask you.
Yeah.
And maybe we should be doing that to get more at capacity.
Sure.
Right?
Yeah,
and sort of tease out that.
And I guess for kids, they 15 to 18 months from some ages, they mature a lot in that time in terms of following their instructions too.
Yes.
And there's all those things that come up. And that's the beauty of doing research like this, is that you just get more questions, and it just allows us to get closer and closer to our ultimate goal, which is to be more precise with what we do. Yeah. What does this mean now, from your perspective, having looked at these results? What would be the main message you'd want clinicians, physios, families to take from this work?
A couple things, maybe. So first, I think the big take-home that's a bit of a relief, both for the surgeons, and for the therapists and for the families, is that very broadly, there's not a loss of muscle strength. Yeah. The way that we measure it by man muscle testing, we don't see any significant loss.
Fantastic.
So I think that can give families some relief, and give us some relief.
Because often that drives a lot of fear going into surgery, doesn't it? And they want to put it off as long as they can. And
right? With the caveat that, as we talked about, we didn't characterize the physical therapy as part of this cohort, but all the children who go through our system would be having physical therapy, would be having a good post-op physical therapy routine. So very broadly, we can find some relief in that there's no long-term loss of strength.
That's fantastic.
And then, as we talked about with the power generation, I mean, my take-home for therapists is, work on this, work on power generation, work on speed, work on,
Yeah, I love that. And there's great research around that area now. Yeah.
Yes.
So Nancy, I've been asking everyone this question. This is a very F-words based conference, and I can see how it's woven into everything that you've done there. What would your advice be, Nancy, for clinicians to implement more of the F-words into their practice? What would that advice be from you?
You're making me think very specifically now, based on the conversation that we just had. I mean, I guess I could think broadly, but I'm thinking about this project that we just talked about.
Yeah, sure.
And so, F words for function and fun. As therapists, walking speed, should be a goal for us.
Love that.
Because it's associated with so many other things, like faster walking speed associated with more walking, with more efficient, less energy consumptive walking. Yeah.
Keeping up with friends and family.
Keeping up with friends and family to do the fun
to be able
things.
Yeah, that's right.
Yes, that I think that's how we can connect to those other F words,
true.
right? That's our role in helping them connect.
Yeah, and I love that. I know we talk about different metrics here, but in Australia we're meters per second people. And one of the stats we often quote is 1 meter per second is what's required to cross the road. When you look at the green light, and it's exciting to know that we can train bodies to increase in strength and in their speed.
Yes.
And when we are able to do that in a targeted way, it's very meaningful for the person, isn't it?
Yes, right. So, I mean, hopefully they translate it then, right, outside of our clinic.
Absolutely.
Crossing the street. And
that'd be key. Oh, Nancy, it was lovely speaking with you about this today. Thank you for doing this work and for sharing this information with us. I know we've created more work for you by kind of going, here are more ideas, but how great is it that you can come to a place like this and out of pure curiosity, everyone asks you more questions to do more work.
Yes, no, it's perfect.
It's so good. To all of our listeners, I hope you really enjoyed that. You know, just yet another area where it's good to do the research and find the evidence about things that we've probably been worried about, but actually when you look at the research, it can point to a different direction. It's fantastic. And we're all in it together. So I hope you've been enjoying it. There's so many more episodes, of course, to come. So stay tuned for so much more. Goodbye.